So good evening all and welcome to the session. I myself, Dr. Bharath Kumar VD. I am the Pharmacology faculty, DBMCI and eGurukul. And in this session, I'll be discussing the high yield questions for the upcoming NEET PG 2022 and the pharmacology questions will be discussed. So the purpose of this is to give you some insight about some of the important points you need to keep in your mind while you attend the exam which is coming in the few days. In few days, you are going to attend that exam. So let us see the questions here. The first one is a question. Let us see this. 51-year-old farmer is brought to the primary health center with the alleged history of consumption of pesticide 30 minutes ago. He is vomiting, sweating profusely with excess salivation, anxious, and his pupils are constricted. He is admitted and given atropine 2 mg IV, which is repeated every 5 minutes. What signs will indicate that bolus atropine injection has to be stopped? So what is the poison we are actually dealing with? The poison which we are actually dealing with is the organophosphate, because the history is telling you is a farmer and he has consumed pesticides. So the typical history will be the pupil is constricted, but how do we know that what is the poison? Now in this case, atropine is given, you will come to the conclusion, but there is something called toxidromes. You have heard of syndrome. Similarly, we have in pharmacology something called toxidromes. So toxidromes will help us in coming to the conclusion what poison we are dealing with, but just with the help of the pupil size. Now let me take into consideration meiosis. So the poisoning which causes meiosis and the poison which causes mydriasis. Now can you tell me which poisons will cause mydriasis? I am writing meiosis. Can you tell me which will cause mydriasis? Meiosis is caused by two poisons. One is the OP compounds and the carbamates, which are used as insecticides and pesticides. And one more is by the opioids. Opioids means the morphine. How do you differentiate that? Both of them will cause meiosis, but how do you difference that? Now remember, the muscarinic actions are predominant in OP and carbamate poisoning. We have given the mnemonic dumbbells: diarrhea, urination, meiosis, bradycardia, MSS, lacrimation, salivation. So these are the typical of OP poisoning. But what about opioids? So in the opioids, patient will be in coma, pupil is constricted, yes, then respiratory depression. Patient will have respiratory depression. Along with that, he will have hypotension, hypothermia, and then hyporeflexia. So these things will give an idea what is opiates. Opiates, you see mainly the respiratory depression, then hypotension, hyporeflexia. So you remember by the mnemonic CPR and 3H, 3 hypo will occur with this: hypotension, hypothermia, and hyporeflexia. Now, what is the treatment for OP poisoning? The antidote is atropine. What is the antidote for opioid poisoning? It is nothing but the drug naloxone. Naloxone is the antidote. We give it by IV. Now, mydriasis, remember two important drugs can produce that. The anticholinergic drugs, which we usually see the anticholinergics, they are the atropine poisoning. So in atropine poisoning, we see this mydriasis, and also in sympathomimetics. For example, cocaine, amphetamine. So recently they had asked cocaine poisoning. Please understand, they want to ask you about the sympathetic overactivity. Now cocaine and amphetamine, remember, they can increase heart rate, they can increase blood pressure. Now anticholinergics also increase heart rate and they increase blood pressure. What about the body temperature? Both will increase body temperature. But how do I differentiate between the anticholinergic and The sympathetic is by this. So in this there will be flushing and there will be paralytic ileus. But here there will be tremors. You know that tremors are because of beta 2 action. And also there will be diaphoresis, excessive sweating. But you don't see sweating in atropine poisoning because the sweat glands are blocked. So this is a toxidrome to understand the poisonings. And if I come to this case, you see that patient is having constricted pupil. You are seeing the vomiting, sweating, salivation, anxious patient, and is a farmer. So for him, we are given atropine. What are the signs of atropinization? Number one, will there be flushing with bradycardia? No. When I use atropine increases heart rate. It may cause flushing, but it will not cause bradycardia. So the signs of atropinization is increase in heart rate. So this is ruled out. Cooling of peripheries with a rise in blood pressure. Atropine can increase blood pressure, but periphery is not cooled. So remember, the sweat glands are supplied by sympathetic, but the neurotransmitter released is acetylcholine. So this will act on M3 receptor and sweating occurs. So now when I give atropine, this M3 receptor is blocked. So what happens? The temperature increases. We call it as atropine fever. So cooling will not be seen. Dry mouth and clearing of pulmonary secretions. Yes, this is the right answer. So when we use atropine, it causes dry mouth, decrease in salivary secretion, decrease in acid secretion in the stomach, and decrease in lung secretion. This is the most common criteria what we use. Most specific, I can tell you it as the most specific criteria. And the most common criteria what we use is the pupil dilation and increase in heart rate. But the most specific is decrease in lung secretion. Now, meiosis with reduced intraocular tension, meiosis is not caused by this. Atropine causes mydriasis. Reduced intraocular tension, remember, anticholinergic drugs, anticholinergics should not be used in angle closure glaucoma. Angle closure glaucoma. It's a very important point they have asked repeatedly. So atropine cannot be used in angle closure glaucoma. Not only that, BPH in elderly. My question to you all, can we use imipramine in angle closure glaucoma? Anyone? Can you answer this? So coming to the question, the answer is dry mouth and clearing of respiratory secretion. So the question doesn't end here. Now, any exam, remember, they always ask the antidote. At least one antidote will be coming, or there will be a match the following question. So what I have done here is, I have written the poisonings. Now, if possible, you can pause the video and just attempt these antidotes. You can pause the video and attempt these antidotes. So OP and carbon poisoning, what is the antidote? Yes, atropine sulfate. Now, atropine poisoning, what is the antidote? It is physostigmine. Many of you confuse physo with pyridostigmine. Why do we prefer physo? Because it crosses blood-brain barrier. That's the reason. Beta blocker toxicity, the antidote is glucagon. Paracetamol toxicity, it is N-acetylcysteine. Now, why it is? Because it produces NABQI. So NABQI stands for N-acetyl parabenzoquinonamine. Now next, digoxin. So digoxin, the antidote is digimine. It is also called as the digifab. It is also called as the digifab. Cyanide toxicity, anybody can tell me? Cyanide toxicity, the drug of choice is hydroxycobalamine. That is the one. And we also use sodium nitrate or amyl nitrate. Sodium nitrate plus amyl nitrate can be used along with sodium thiosulfate, but this takes time. So the best one to treat cyanide toxicity is hydroxycobalamine. Heparin, low molecular heparin, protamine sulfate. Warfarin, anybody? What is the antidote for warfarin? Yes, it is vitamin K. But if the patient comes with bleeding with warfarin, immediately you have to reverse, then use, what is that? 4-factor prothrombin complex. Dabigatran, remember, the antidote is idarucizumab, and please read the name, Da. Ends with EDA, inhibits DABI ganglia. So in the exam, you need not remember the whole drug. You should know the clue. That's it. Oral 10 inhibitors, antidote and hexanate alpha. You read the name. Hexa, it is having XA. Benzodiazepine, Z drugs, and beta carbolin. What is the antidote? Flumazenil. And majority of you will confuse this. Flumazenil with fomepizole. Now, fomepizole is an antidote for what? Fomepizole is for alcohol, particularly ethylene glycol and methanol poisoning. The antidote what we use is fomepizole. How to avoid the confusion in the exams? Flumazenil. Fomepizole has OO. Alcohol has OO. What about valproate hyperammonemia? The drug used is carnitine. Neuroleptic malignant syndrome. What is the drug of choice? It is dantrolene sodium. And the drug of choice is dantrolene sodium. If they ask you antidote, please note down. Antidote is bromocriptine. But if they ask you drug of choice, it is dantrolene. Only if you see the word antidote, the answer should be bromocriptine. Opioids, just now I told you, naloxone. Sulfonylurea-induced hyperglycemia, octreotide. Drug-induced dystonia, very commonly asked. Which drugs can cause that? Atypical antipsychotics. Antiemetic, metoclopramide can cause it. So the drug used is central anticholinergic like benztropine can be used. You can use benzexol. If it is not available, we can use first generation antihistamine, that is promethazine. Promethazine can be used. What about methotrexate toxicity? You can use leucovorin. Leucovorin is also called as folinic acid, also called as citrovorin factor. Nowadays, we have an enzyme for methotrexate toxicity that is called glucarpidase. What about calcium channel blocker toxicity? Give calcium gluconate with high dose of insulin. Methemoglobinemia. We use methylene blue. INH-induced seizures, obviously pyridoxine. Fibrinolytic overdose, what do we give? Antifungal, that's it. And you check your question bag, everywhere this list is there. But let me ask you one question. What is the antidote for magnesium sulfate toxicity? And it is the calcium gluconate. So very beautiful list. And they keep on asking this antidotes. And please go through this list of antidotes. You can pause this video, look into this and revise it faster. Okay, so we are done with the first question, and I had asked you a question: will imipramine be used in angle closure glaucoma? No, because imipramine is a tricyclic antidepressant, which is also blocker of muscarinic receptor. It is an anticholinergic drug, so it is not used in angle closure glaucoma. Yes. So we're done with the first question. Let us move to the second question. What is the second question? A pharmacokinetic question. Will they ask this type of pharmacokinetic question? Yes, they are coming. A drug with a half-life of 6 hours. It is administered by continuous intravenous infusion. How long will it take for a drug to reach 50% of steady state plasma concentration? Now remember, to achieve steady state, what is steady state? It's a state where rate of drug entry equals to rate of drug exit. How many half-lives are required to achieve steady state? I'll write the steady state by like this. So steady state is like the CPSS. Steady state. To achieve steady state, you could require 4 to 5 half-lives. So we all know this concept. But recently they are asking this: how many half-lives are required to achieve 50% of steady state? You require only 1 half-life. 75%, how many half-lives do you require? Is 2 half-life. 87%, how much you require is 3 half-life. But very, very important is a 90% steady state. For that you require 3.3 half-life. Let me come to this question. What is the question? They are asking how many half-lives, how much time is required to reach 50% of steady state. So half-life is 6 hours. So if I take this 50%, 1 half-life, 1 into 6 hours. So how much is required? it is 6 hours. So please remember, pharmacokinetics equations have become mandatory in the pharmacology section, particularly NEET PG. So let me give some formulas for you. What are the ones which are important? Just a minute. Okay, so some of the formulas which are important is, let me give you, half-life can be given by 0.693 divided by elimination rate constant. Half-life is also given by 0.693 into volume of distribution divided by clearance. Another important formula is maintenance dose. Maintenance dose is equal to target plasma concentration into clearance into dosing interval divided by F bialbetic. What about loading dose? Loading dose is equal to target plasma concentration into volume of distribution divided by bialbetic. So they had asked you a question, maintenance dose depends on what? Clearance. Loading dose depends on what? Volume of distribution. And please understand one more important aspect. I'll rub this off. I'll show you. One more important aspect is the dosing rate. So dosing rate is given by this. Dosing rate is equal to clearance into total plasma concentration. So this is dosing rate. Then they will ask you hepatic clearance. Hepatic clearance is given by the formula hepatic blood flow into hepatic extraction ratio. So these are the formulas. Please keep in mind, they are asking this repeatedly. Next, let me move to the third question. 12-year-old girl presents to your office, that is your OPD, sore throat and fever. You diagnose her with pharyngitis caused by group A beta hemolytic streptococcus. She is given an IM injection of penicillin. Approximately 5 minutes later, she is found to be in respiratory distress. Audible wheeze, her skin is mottled and cool. She is tachycardic, heart rate is high, her blood pressure is lesser. You immediately diagnose her as a case of anaphylactic reaction to the penicillin, which will you give to the patient. So they have diagnosed that anaphylactic shock is a very important point. Whenever there is anaphylactic shock, the best drug to be used is adrenaline. So adrenaline 1 in 1000 intramuscular, which muscle is preferred is the vastus lateralis. Vastus lateralis, and how much to be given is 0.5 milligram. This is the dose you should remember. But adrenaline is a very important drug for your exams. They will ask you the dilutions and its uses. So if the adrenaline use is between 1 in 1000, so this dilution is used, remember, IM and subcutaneous for anaphylactic shock and also for nebulization. Where do you do nebulization? One is for bronchospasm due to anaphylaxis, number 2 for croup. 1 in 10,000 dilution of adrenaline is used for what? It is used for same anaphylactic shock, cardiac arrest when you are doing CPR and severe bradycardia. Which routes do we give 1 in 10,000? IV, IO, and also endotracheal. 1 in 50,000 to 2 lakhs. This dilution, we use it when we are using along with local anesthesia like lignocaine. Now, coming to the other options. Yes, we understood the adrenaline option, very good. But what about noradrenaline? Remember noradrenaline specialty. Noradrenaline increases all the pressures, systolic, diastolic, and mean arterial pressure. But penultimately, it is going to cause reflux bradycardia. So what is the use of noradrenaline? It is used in shock, septic shock, cardiogenic shock, where the BP is less than 70, systolic less than 70. So the main thing what we monitor when we give noradrenaline is mean arterial pressure that will rise. Isoprenaline main action is on beta 1 and beta 2. So it is used for treating bradycardia and AV block. Now, another important drug, the examiner favorite, is dopamine. Why dopamine? Because its action varies with the various doses. Infusion, for example, 1 to 2 microgram per kg per minute. So this infusion, the drug acts on D1 and increases renal blood flow. If we increase it to 2 to 10, then it acts on beta 1 and increases force of contraction. So if a patient is having cardiogenic shock with oliguria, then the preferred drug is dopamine. Why? Because it increases renal blood flow and it can correct oliguria. More than 10 acts on alpha 1 and can cause vasoconstriction. So remember, dopamine, a very beautiful drug for examiner. Adrenaline again, noradrenaline again. And they have asked repeatedly the levels, what do they do? Okay, so this is a case of anaphylactic shock, and the drug of choice for anaphylactic shock is adrenaline, 1 in 1000, IM, best is vastus lateralis, 0.5 milligram. Please never forget that. I told you the dilutions. Once we are done with that, let us move on to the next question. Which of the following is the most appropriate drug to use for a patient described in the following scenario? So you have to tell me the appropriate scenarios. So captopril for a 60-year-old woman with diabetic nephropathy, can we use it? Yes. What is captopril? Captopril, anything ending with pril, is a AC inhibitor. And is it useful in diabetic nephropathy? Yes. Why? Any prils, AC inhibitors or ARBs, they are known to decrease microalbuminuria. Microalbuminuria. Now, when it decreases microalbuminuria, it is good for diabetics, and diabetics will have microalbuminuria. Not only that, it decreases intraglomerular pressure, which is good in CKD. So, patients having diabetic nephropathy or CKD or simply microalbuminuria, we can use AC inhibitors. So, this is the right option. But let us see the other options. Nitroprusside for a 50-year-old man with a BP of 140/95. Now, nitroprusside is an IV drug, and a person 50-year-old has having stage 1 hypertension, 140/95. It's not an emergency or urgency. So, nitroprusside is a drug which is preferred in urgencies or emergencies. Mainly, it is in emergency where there is end organ damage. We use IV drugs. Oral drugs, we use it in urgencies. Now, in this patient, you can start with first-line drugs like AC inhibitors or ARB, calcium channel blockers, and diuretics. So, we can start with AC inhibitors or CCBs or thiazide diuretics. This can be used. Now, moving on to the next one, the losartan. Now, losartan to a 29-year-old pregnant woman, can we use it? No, this we cannot use. Losartan, why? Losartan AC inhibitors, they are contraindicated in pregnancy. So remember, what are the drugs avoided in pregnancy? Avoid. Number 1, AC inhibitors, ARBs. Don't use it in pregnancy because they are found to have produced renal agenesis, particularly in second and third trimester. Even the renin inhibitor like alascarin should not be used. Then sodium nitroprusside. Why? Sodium nitroprusside generates cyanide. So cyanide may be toxic to the growing fetus. Now another important drug is spironolactone. Why not spironolactone? Because spironolactone is having androgen blockade property. Suppose the fetus is a male fetus, so it will undergo virilization. The other drugs which are avoided are thiazides in pregnancy because they will interfere with uteroplacental circulation. Atenolol and non-selective beta blockers. Non-selective beta blockers should be avoided because they have shown to increase the risk of small for gestation babies. So is it appropriate to give losartan to a 29-year-old pregnant woman? No, you cannot use it. Propranolol for a 40-year-old patient with peripheral vascular disease? No. Non-selective beta blockers like propranolol, timolol, nadolol should not be used in diabetic, peripheral vascular disease, bronchial asthma, COPD patients. So in these patients, the preferred one is cardiac beta blockers. But when do we choose propranolol as an antihypertensive? We can choose when the patient is having hypertension plus risk of arrhythmia, patient is having migraine, post-MI patients, patient having anxiety, right, tense personalities. So then we can prefer that. So this is also ruled out. So what is the best answer is captopril for a 60-year-old woman with diabetic nephropathy. That is the appropriate one. Moving on to the next one, which of the following is correct regarding the mechanism of action of thyroid hormones, that is T4 and T3 at the thyroid hormone receptor? Now, what is this thyroid hormone receptor? Thyroid hormone receptors are the one which are located in the nucleus. So when the drug thyroid hormone bind to nucleus, they will either stimulate or inhibit the gene transcription. From there is stimulation or inhibition of protein synthesis. So this is what the nuclear receptors will do. Now if I read the options, activate phosphatidyl inositol DAG calcium cascade, that is the GQ receptor. Act by increasing cyclic AMP is the GS, and the GI will decrease the activity of cyclic AMP. Tyrosine kinase, remember the enzyme tyrosine kinase is activated by insulin like growth factor 1, and any growth factors will activate this, growth factors. Now remember, what about growth hormone? The meaning of growth hormone, that is JAK-STAT. JAK-STAT, through this pathway the growth hormone works. The interleukins work, cytokines work, and even the prolactin works by JAK-STAT pathway. So this thyroxine works through nuclear receptor, so it will activate nuclear transcription factor. Not only that, the corticosteroids, the sex steroids, vitamin A, vitamin D, and then the PPR and thyroxine, they act through this. So the answer to this is D, activating nuclear transcription factor. Let's move on to the next one. 45-year-old male diagnosed with HIV, CD4 counts are 300 lesser, viral load is high. Which of the following will help as prophylactic in preventing pneumonia due to pneumocystis cereus in this patient? Is it clotrimazole, ciprofloxacin, cotrimoxazole, clindamycin? Now please remember, clotrimazole is the one which is used for prophylaxis of pneumocystis cereus. It's a drug of choice for isosporiasis, then cyclosporiasis. Not only that, they are used for pneumocystis cereus, nocardiosis, and Burkdoleria cepacia. Now when we think of the answer, it is not clotrimazole. I purposefully told you that to make you confused. Remember, it is not clotrimazole. It is cotrimoxazole. Nobody answered that. Cotrimoxazole is the antibacterial drug. And remember, clotrimazole is an antifungal drug. And this is the confusion you all have in your exams. Remember, it is made up of true trimethoprim and sulfamethoxazole, that is the one. What about ciprofloxacin? Ciprofloxacin mainly asked for its use in management of UTI, diarrhea, and also it's one of the drug which is used as drug of choice for typhoid carriers. So typhoid carriers is the drug of choice. Clindamycin, when you think of clindamycin, remember clindamycin is mainly asked for adverse effect. What is that? It mainly produces pseudomembranous colitis. When we use clindamycin, there is a risk of pseudomembranous colitis. The drug that, the bacteria which affect is Clostridium difficile. What is the drug of choice? Recent update for pseudomembranous colitis, the first choice is the oral fidaxomicin. Oral fidaxomicin is the first choice. Okay, so remember, whenever the HIV questions are asked, what are the other prophylaxis we need to know of? Tuberculosis, they are prone for tuberculosis. Now, what is prophylaxis? You can give INH. Another important is cryptococcal. They are prone for cryptococcal infection. Then what is the prophylaxis? Fluconazole prophylaxis should be given. Right? These are the two things they keep on asking you. What is the prophylaxis for this? Any new drug for HIV which has come to the market, remember there is a drug called crofelemer. Crofelemer is a new drug which is known to inhibit chloride channels, and it is used for HIV associated diarrhea. So HIV diarrhea, crofelemer is used. One more drug which is asked is cobicistat. It also starts with C. Anything ending with stat in pharma, remember their purpose is enzyme inhibition. It is a pharmacokinetic booster. One more important aspect is ibalizumab. Ibalizumab is also a drug which is approved for HIV-1 only, and it is shown to inhibit the entry process. It inhibits the entry process of virus. So that is about the HIV updates, what has to be learned in your preparations. So prophylaxis of TB, Cryptococcus, crofelemer, cobicistat, ibalizumab. Remember, when the patient is diagnosed with TB and HIV, what should be treated first? Treatment should be TB, and after 2 weeks, it has to be HIV. Otherwise, the patient will end up with IRIS. Moving on to the question number next one. A 56-year-old man with a history of type 2 diabetes present to a physician for a follow-up. He complains of repeated episodes of sweating, tremors, and palpitations while going for morning walk in empty stomach. Which of this medication is most likely responsible for patient's complaints? Now, if you read this sweating, tremors, palpitations, it is a sign of hypoglycemia. So which diabetic drugs they can produce hypoglycemia? They are insulin, sulfonylureas, and meglitinides. These are the only drugs which can produce hypoglycemia. Even GLP-1 can cause, but their risk is increased when you add with insulin, that's it. But exclusively these are the 3 drugs which cause hypoglycemia. So if I read the option, repaglinide, it is what? Nataglinide, repaglinide is a meglitinide. Yes, this can cause. Glucagon, never. It is a drug which increases glucose always. Metformin, they are called as anti-hyperglycemic. They don't decrease the glucose further. They will, if the glucose is high, they will make it to normal, not below that. Acarbose is an alpha glucosidase inhibitor. Not only this concept, in the exam they keep on asking in diabetics some of the complications. Now, what is the drug which can be used for both diabetes type 1 and type 2? Only 2 drugs are approved. One is insulin and one more is pramlintide. These are the things. Now, what are the drugs which are given as injections? It is again insulin, then pramlintide and GLP-1. Now, a recent update should be understood. A GLP-1 agonist, usually it is given injection, but a drug can be given both injection as well as oral. What is that name? And that is called semaglutide. Semaglutide is a GLP-1 agonist which can be given oral as well as subcutaneous injection. Then they will ask you which will cause weight gain. Weight gain is the older drugs, insulin, pioglitazone, sulfonylurea, meglitinides. Which will cause weight loss? Weight loss is the pramlintide, the SGLT2 inhibitors, and then the GLP-1. Which will call weight neutral? Weight neutral are metformin, then DP4 inhibitors. So these are the things they ask you in the exams. Now recently there are some questions like which drugs will increase the risk of UTI? Which drugs can increase the risk of diabetic ketoacidosis? They are nothing but the SGLT2 inhibitors. In SGLT2 inhibitors, which can increase the risk of amputations, increased risk of amputations mainly seen with canagliflozin. Right, so the risk of fracture, increased risk of fractures is mainly seen with pioglitazone, as well as SGLT2 inhibitors have shown to increase the risk of fractures. Now remember, SGLT2 inhibitors also have shown to increase the risk of genital fungal infections. But one specialty of SGLT2 inhibitors is they can also decrease mortality in chronic CHF. Very, very important. This is the point they keep on asking you. Which drug in diabetes can decrease mortality in CHF? SGLT2 inhibitors. SGLT2 inhibitors. Now, among DP4 inhibitors, which drug is safe in renal failure? It is the linagliptin. Right? So this is the points you need to note down. Moving on to the question. Patient was put on carbamazepine for GTCS. His seizure episodes were controlled for 1 month. After 1 month, he had 2 episodes of seizures in 2 following weeks. What is the next step? Now, carbamazepine is an anti-epileptic drug and it was given for generalized tonic-clonic seizure. It was controlled for 1 month. After 1 month, he had again episodes. What is the problem with carbamazepine? Remember, there are certain anti-epileptics which are enzyme inducer: carbamazepine, phenytoin, phenobarbital. These are enzyme inducers. Now, what is the problem with carbamazepine? It can induce its own metabolism. So, it will induce its own metabolism. That means it can decrease the drug levels. So, if the drug levels decreases in the body, in the circulation, obviously epilepsy increases. So, please note down this. When you start carbamazepine, after 1 month, again the episodes of seizure occurs. It is because of autoenzyme induction by carbamazepine, and there will be decrease in drug levels. So what would I do? I have to increase the dose of carbamazepine. That's the right answer. No need to decrease the dose of carbamazepine. Shift to other anti-epileptic only when we cannot control with carbamazepine. First increase the dose, still not control, then we can change. Advised IV diazepam during episodes. Now, we have to use prophylactically these drugs. Benzodiazepines are not used for prophylaxis because they develop tolerance and we use them for only emergencies. So, what is the drug of choice for status epilepticus? Drug of choice for status epilepticus is IV lorazepam. If that is not there, diazepam can be given. One more important thing many of you asked me is, what about the absence seizure? Now, if they have not given any age, nothing, absence seizure means the drug of choice is valproate. Now, if that is childhood, if they are given in childhood absence seizure, then the answer will change to ethosuximide. Only if they have given the childhood cases, you go for ethosuximide. If they have not given anything, then you can go with valproate. Now remember, carbamazepine is also drug of choice for a neurological condition. Anybody can mention that? Where? It's a drug of choice for what condition? Come on. Trigeminal neuralgia. Trigeminal neuralgia. So answer here is A. Now moving on to the next question. Resident doctor developed needle prick injury while taking blood sample of HIV positive. Which of the following is best for post-exposure prophylaxis? Very, very important point. Now the guideline has changed. So post-exposure prophylaxis, what we prefer is the TLD regimen. So remember, post-exposure prophylaxis, remember, minimum 3 drugs should be used and they should be used within 72 hours. And the 3 drugs should be used for minimum 28 days, that is 4 weeks. So the best one in that is the combination of tenofovir, lamivudine, and dolutegravir, which is an integrase inhibitor. TLD regimen is the one which is recommended in adults now. Now remember, zidovudine, stavudine, you should not combine them because of pharmacological antagonism. If that is not available, you can go with other options, but best one is this one. Now, what is the problem with tenofovir? Tenofovir, the adverse effect is it decreases bone mineral density, and also it causes renal toxicity. Renal toxicity, that's the problem. But if a pregnant lady has hepatitis B, what is the best one? Hepatitis B in pregnant women. Then the best one is TDF, that is called tenofovir disoproxil fumarate. This is the one which can be used. Tenofovir disoproxil fumarate. Okay, so otherwise hepatitis B, the drug of choice are either tenofovir or you can use entecavir. Only if the patient is having renal failure, then you can only give entecavir, right? Yes, moving on to the question, which one of the following drug is most suitable in an immunocompromised patient for prophylaxis against infection due to Cryptococcus? So I have told you already, for Cryptococcus neoformans, the prophylaxis is fluconazole because it's an oral drug easily given. Suppose the question is, patient is having cryptococcal meningitis. Cryptococcal meningitis, so it's an emergency. That time, you give parenteral drugs like liposomal amphotericin B. Liposomal amphotericin B. Along with that, you can add flucytosine. This can be used. This liposomal amphotericin B is the drug of choice for a condition, fungal condition called mucormycosis. A very commonly asked question nowadays. Not only that, it is also used as drug of choice for visceral leishmaniasis. What is the only oral drug available for leishmaniasis? The name is miltefosine. Nystatin is a topical antifungal drug. Ampicillin is an antibiotic. It's a beta-lactam. Ampicillin is now preferred for listeriosis and Enterococcus fecalis. So ampicillin is preferred. Right? Now remember, one important fungal infection they ask you is, what is the drug of choice for invasive aspergillosis? For invasive aspergillosis, the drug of choice is oriconazole. So many of questions come, sir, is postconazole, isoconazole drug of choice mucormycosis? No, mucormycosis, it is liposomal amphotericin B. Postconazole, isoconazole are newer drugs. They are available for mucormycosis, but they are not the drug of choice. Right? Yes. Moving on to the next one, lithium, a very favorite for examiner. Remember, lithium in and out, every day, exam lithium is there. Was given for bipolar disorder patient. The patient developed coarse tremors after 2 weeks of therapy. The physician advised to do plasma levels monitoring of lithium, and the ideal time for lithium estimation is. Now, patient has developed coarse tremor. Now, first of all, do you know the adverse effect of lithium is a question. Lithium is one of the wonder drugs which are used in mania, bipolar disorder, but the half-life of the drug is 24 hours. Now, when we use this drug, steady-state plasma concentration is achieved in how many days? You know that 4 to 5 half-life, so it will take 4 to 5 days. And lithium is a narrow therapeutic index, so we have to do therapeutic drug monitoring. Monitoring means we have to measure the level of lithium. What the ideal time is 4 to 5 days we start the therapy, and after that, if the patient takes at 9 a.m. in the morning, so the drug will peak by 10 to 12 hours. So the ideal time is after the drug is taken, after 10 to 12 hours, that's the best time to take it. Now, when we talk about TDM, what are the drugs which require TDM is a big question. Now, I will give a mnemonic. Look at TDM concentration. L for lithium, A for anti-epileptics, amyloglycosides, theophylline, TCS, digoxin, anti-cancer drug, methotrexate, C for calcineurin inhibitor. Can you tell me the name? Cyclosporin and tacrolimus. So many of you confuse cyclosporin with cycloserine. Cycloserine is a drug for tuberculosis. Sporin, an immunosuppressant. Now after that, what are the adverse effects of lithium? Lithium can produce alopecia, acne, weight gain. Now fine tremor is commonly seen. Fine tremor is the most common. Okay, then Epstein's anomaly. So it's one of the serious defect when we give the drug in a pregnant woman. They may end up with teratogenicity. Then leukocytosis. They can increase the leukocyte count. Then diarrhea, loose stools. And then high dose. So when you feel that high dose of lithium is there inside the blood, it is seen whenever there is coarse tremors. So patient is having coarse tremors, that means high level. Then tinnitus, diarrhea. These all will tell us patient is having higher doses. Now what factors will increase lithium toxicity is whenever there is hyponatremia. Now when you can see hyponatremia is with diuretics like thiazide or loop, when the patient is having diarrhea, fasting, so there is loss of sodium. So when the sodium is lost, along with sodium, the lithium is also reabsorbed from the PCT. So the risk of this thing is seen. And also it can produce hypothyroidism. Right. Then it can cause ECG changes. It's not such a bigger thing. And nephrogenic diabetes insipidus, the drug of choice for that is amiloride. So these are the problems what are seen with lithium. And when to do the lithium estimation, remember 12 hours after the last dose. I told you just now 9 a.m. then 10 to 12 hours after the last dose. That's the best time to do this. So lithium is a must know drug in and out. Moving on to question number 58. Question number next one. A 58-year-old male patient had BMI of 35. Physician started a drug for managing obesity. The drug also lowers glucose and given via parenteral route. What is the drug? Naltrexone. Naltrexone is used in obesity, but it is used along with bupropion. Lorcaserin was used one time. It's a 5-HT2C agonist. It was used for obesity, but recently discontinued because of increased risk of cancers. Linaglutide, remember glutide is a GLP-1 agonist. Sorry. It is used for treating obesity, and also it is a drug which can be used in diabetes. So the answer will be C. Orlistat is an inhibitor of lipase. It's an inhibitor of lipase. The adverse effect is steatorrhea. So here the answer is liraglutide. So remember, obesity is one of the important things. But also smoking cessation. What are the drugs for smoking cessation is a commonly asked question. Varenicline, bupropion, and nicotine replacement therapy. So these are the therapies we have, but which one is most efficacious is varenicline treatment. 28-year-old male complains of 3 days of dysuria and a purulent urethral discharge. It's a case of gonorrhea. You diagnose this a case of gonorrhea. Which of the following is appropriate? Remember, gonorrhea nowadays we are preferring a single drug therapy, that is ceftriaxone. So that is the answer for this. But ceftriaxone is also a drug of choice for a STD called chancroid. Not only that, remember when the ceftriaxone is asked, they are going to ask you the drug of choice for typhoid is this one. And not only that, it is the empirical drug of choice for meningitis. So when you don't know the diagnosis, then you treat it with ceftriaxone, but ceftriaxone doesn't kill listeria. Penicillin G, remember, mainly in penicillin, benzathine penicillin is the drug of choice for all stages of syphilis. All stages of syphilis, but except one, neurosyphilis, the drug of choice is aqueous penicillin. Gentamicin is not used. Piperacin is a distractor. Now, piperacin tazobactam, this combination can be used for ESBL producing E. coli or Klebsiella. A combination of beta-lactam plus beta-lactamase inhibitors are used for ESBL producing E. coli or Klebsiella. Now, other STDs are also asked: lymphogranuloma, granuloma inguinal, chlamydia. For all these STDs, the drug of choice is doxy. If doxy is not there, next you can go for acitro. Now, what is the other STDs they ask you is herpes. Herpes, the drug of choice is acyclovir. What about the other STDs? Yes, we are done with that. Bacterial vaginosis. Then another important Trichomonas vaginalis, the drug of choice is metronidazole. So Trichomonas vaginalis, it will present as strawberry vagina, and bacterial vaginosis will have clusters. So they don't give you a diagnosis, they will give this hint and they will ask you the questions. Right? 58-year-old patient is diagnosed with ovarian cancer, started on cisplatin, but complains of severe vomiting after 6 hours. Which is the most effective one? Remember, 6 hours after starting chemotherapy, it is called early. For early CANV, the drug of choice is ondansetron. Late CANV, what we use is the neurokinin 1 antagonist and apripitant, they end with pitants. Droperidol, it's a D2 blocker. Prochlorperazine is a D2 blocker. Metoclopramide is a D2 blocker. Now all these drugs can cross blood-brain barrier and they can cause D2 blockade in the brain. So when they block D2 in the brain, the problem is they can produce extraepidermal symptom, and the extraepidermal symptom is acute dystonia and oculogyric crisis. Along with that, drug-induced Parkinson's. So how do you treat it? What's the treatment for acute dystonia caused by metoclopramide? A very frequently asked question. Repeatedly they are asking metoclopramide for this adverse effect. What's the treatment? Yes, Sharon? What is the treatment for the EPS caused by metoclopramide is benzexol, or you can use promethazine. Now, a 65-year-old woman is being treated with roloxifene for osteoporosis. What is the risk for? Now, roloxifene is a SERM and it is an antagonist at breast, peripheral tissue and endometrium. So, breast cancer risk will be reduced. Endometrial cancers will not occur. So, peripheral tissue, if it blocks, there is a risk of flushing. That is called hot flushes. So, roloxifene can cause hot flushes, but it's a partial agonist at liver, so it can increase clotting factors and increase the risk of venous thromboembolism, but it is good for osteoporosis, so we use it in postmenopausal osteoporosis. The problem what we face with this is venous thromboembolism and hot flushes. So what is the risk? Breast cancer risk is not there. We actually use roloxifene to prevent it. Uterine cancer is not there, or deep vein thrombosis is the risk what we see. Even atopic vaginitis may be seen, but the DVT is the major risk factor with roloxifene. Suppose if they change the question, tamoxifen, then if you use tamoxifen, then what is the risk? The risk is increased risk of uterine cancer, increased risk of deep vein thrombosis, increased that is VTE, and increased risk of hot flashes. That is seen with tamoxifen. Problem with tamoxifen is the risk of increased endometrial cancer, that is uterine cancer. Moving on to the next one. 45-year-old male comes to casualty with severe headache. Neurologist attends the patient and orders investigation. After examination, doctor decides there is increased intracranial pressure. What is the drug of choice or situation in diuretic of choice? So any increase in intracranial pressure, the diuretic of choice is mannitol, which is osmotic diuretic. But mannitol should not be used in certain condition. Contraindication is commonly asked. Pulmonary edema. If there is cerebral hemorrhage, active bleeding is occurring, then we don't use it. Cerebral hemorrhage. And we don't use it in already established renal failure. We can use it in impending renal failure, but not in already renal failure patient. Furosemide is a diuretic of choice for pulmonary edema. And acetazolamide is the one which is preferred as a drug of choice for acute mountain sickness. Acute mountain sickness. Thiazides, they don't work in renal failure. Even in when the GFR less than 15 ml per minute, the only one thiazide works, and that is called metolazone. So if that is not in the option, you can also think indapamide, which can work in the renal failure. So less than 15 ml per minute, also the thiazide that works is metolazone. 40-year-old patient on chemotherapy for NHL, non-Hodgkin lymphoma, leukocyte is 2000, which is the effective drug. Now the effective drug is filgrastim. It is a GCSF. Oprelvelkin is interleukin 11 analog. Interleukin 11. It is used when there is decrease in platelet count due to anti-cancer therapy. Epoetin, it's a erythropoietin analog. Epoetin, darbepoetin, whenever there is anemia due to CKD. Zidovudin. Yes, Charan, you are right. Or because of anti-cancer drugs, we use this. Now the drug amifostin, it is a radioprotector. Not only that, amifostin is also used to treat cisplatin-induced nephrotoxicity. Okay, so the answer here is filgrastim. Now please note down the anti-cancer therapy, the common adverse effect, and how do you prevent is also important. Patient on antipsychotic therapy for 1 month develops feeling of restlessness, frequent repetitive stereotype movements, inability to sit still for more than a short period of time. Which of the following is responsible? Remember, the extrapyramidal symptoms due to D2 blockade is a very commonly asked question. So here the patient is developing akathisia, inability to sit at one place, and which is responsible is the typical antipsychotics which block D2. So clozapine is an atypical one, and it causes less EPS. Imipramine is a TCA, and it can block alpha muscarinic histamine receptors. Haloperidol is the one which can produce this, so it's a D2 blocker, typical antipsychotic which can cause akathisia. So what is the treatment for akathisia? Treatment is propranolol, sedate a patient with benzodiazepine. Fluoxetine is a SSRI, and in antidepressant, maximum sexual dysfunction is produced by SSRIs, then SNRI, and then TCS. Now, can you tell me the drug which doesn't produce sexual dysfunction? Antidepressant which doesn't produce sexual dysfunction. Anybody? They are mirtazapine, then bupropion, a new drug which has come to the market, that is vortioxetine, and vilazodone. So these are known to produce lesser sexual dysfunction. Now remember, drug-induced EPS like acute dystonia, Parkinson's disease, we use benzaxol or promethazine. Akathisia, I told you. Dyskinesia, we can use valbenazine or deutetrabenazine. Right? Perioral tremor, there is no effective treatment for this. But neural malignant syndrome, the drug of choice is dantrolene. The antidote is bromocriptine. 66-year-old patient hospital-acquired microbial infection while staying in hospital. He is hypertensive and also creatinine clearance very less, 25 ml. Which of the following antimicrobial drug is least likely to require a dose adjustment? Now we know that gentamicin is nephrotoxic. Imipenem can accumulate because it goes in the kidney. Vancomycin. So the safest one is ceftriaxone. This is the best answer. So among cephalosporin, cefoperazone is also safe in renal failure. You can give without dose adjustment. Other nephrotoxic drugs absolutely not given in renal failure. They are amphotericin B. So if you want to give it at lesser dose, and they are nephrotoxic. What I am writing is nephrotoxic drugs: vancomycin, amphotericin B, the platinum compound cisplatin, and imipenem. What happens if you give in renal failure? There is a risk of seizures. So imipenem will be higher level, and the risk of seizures can increase. Arshita Reddy, why cannot imipramine be used in angle closure glaucoma? Because imipramine is an antidepressant which is also a muscarinic blocker. So muscarinic blocker means anticholinergic drug. So anticholinergic drugs should not be used in angle closure glaucoma. If you use that, what happens? The angle between the iris and the cornea will close because they cause mydriasis. So no mydriatic should be used in angle closure glaucoma. Yes, Charan, you are right. Now the last question: immunosuppressant drug was used for liver transplant. The drug is known to bind to cyclophilin and inhibit the action of calcineurin. It is known to cause gamma aplasia and hirsutism. What is the drug used? Remember, it's a case of organ transplantation. The drug is bind to cyclophilin and it inhibits calcineurin. And along with that, they have given adverse effect gamma aplasia and hirsutism. So the drug is cyclosporin. Tacrolimus binds to FK binding protein and then inhibits calcineurin. But it will not cause gamma aplasia hirsutism, but it is highly nephrotoxic, neurotoxic drug. Sirolimus, it's an mTOR inhibitor used for stents. Aldesleukin is an immunostimulant. It's an interleukin 2 analog used in RCC and melanoma. Right? So the answer is cyclosporin. Don't confuse with cycloserine. What are the other drugs which can cause gamma aplasia? One is cyclosporin. The others are CCBs and one more is phenytoin. What are the drugs which can cause hirsutism? One is cyclosporin and one more is phenytoin. Can you tell me an anti-epileptic which is an enzyme inhibitor? Anti-epileptic which is an enzyme inhibitor is valproate. Okay guys, so in this session I have tried to cover majority of the questions and we have tried to finish it off. We took 20 questions and I tried to highlight what are important, what has to be concentrated, which drugs are more important for exams. Hope this will help you for NEET PG 2020 preparation. And the INSCT is done. So only point you can take from INSCT is take the question, know the answer. That's what. Whether you are done well or not doesn't matter. Please leave that exam. That exam is gone. You should not worry about that. Whether you are done well, be happy. Prepare for NEET PG also. If you are not done well, still be happy. Leave that. Only thing is, what are the questions? See to that and get those questions, get the answer, and prepare for NEET PG 2020, which has a huge hope. And I wish you all the very best for the upcoming NEET PG 2020. Main thing in any exam is confidence, revision. So once you have done the revision, confidence will come. Go with the confidence. You have done your best and you will do the best. Thank you all. Take care. Good night.